Right. Welcome again, everyone. I know that some people are still getting logged in. We are going to go ahead and get started with our introduction. Welcome to today. My name is Amy Forbes. I'm the training manager with the Northwest Mental Health Technology Transfer Center, or otherwise known as MHTTC. I'd like to welcome you to today's webinar, Sexual Health, an Essential Part of Recovery. Our two presenters today are Lydia Chawastiak and Lori Silla. We are presenting this webinar today in partnership with the AETC of Mountain West. So today's presenters, Dr. Chawastiak is a psychiatrist, internist, and health service researcher who is a professor at the UW Department of Psychiatry and Behavioral Health Sciences. Over the past 22 years, her research has focused on improving care and outcomes for people with complex needs in low resource settings, such as low barrier primary care clinics and community mental health centers in the US, and primary and secondary medical settings in India and Nepal. She also co-directs UW Behavioral Health Research in HIV. This is at the Birch Center, a NIMH-funded AIDS Research Center, and is the PI and co-director of the Northwest Mental Health Technology Transfer Center. We also have Lori Silla with us today. She has been involved with AIDS since the early 1980s as an agency program director, direct service provider, advocate, researcher, coalition leader, and educator. She is a co-founder of the AIDS Council of Northeastern New York and the Community Research Initiative of New England. She is currently the director of Mountain West AIDS Education and Training Center based at the University of Washington. Before we get started, I'm going to go through and tell you a little bit about the MHTTC network. We are a nationwide network supported by SAMHSA. Our network includes 10 regional centers and a network coordinating office out of Stanford University. And you can see at the top in the pink circle, that is the Northwest MHTTC, Region 10, which includes Alaska, Idaho, Oregon, and Washington. Our goals at the Northwest MHTTC are to support mental health-related evidence-based practices, heighten awareness, knowledge, and skills of the behavioral health workforce, foster alliances, and address diversity of training needs, and to share free publicly available training and technical assistance. Our areas of focus include evidence-based practices for psychosis, which is CBTP, and ACT, or assertive community treatment. And you can please check out our website where you'll find a ton of things that we offer, including future live webinars and past recorded webinars. We also have virtual learning communities, online self-paced courses through Healthy Knowledge, and we have a weekly newsletter that goes out, so please do sign up for that if you haven't already. We also have a resource library and a podcast called Putting It Together. At the end of this webinar, you will receive an evaluation, and we do want you to know that your feedback is very important to us. We would appreciate everybody's response to that evaluation. Our team will share that link in chat today, and then you'll get a reminder email via Zoom tomorrow. We do note that we are required by SAMHSA to conduct the evaluation, yet they do not have any official position on the content that we provide. With that, I will hand it off to Lori to introduce the AETC.
Hi. The The AIDS Education Training Centers, otherwise known as the AETC network, is the workforce training arm of the National Ryan White program, and we are funded by HRSA, the Health Resources Services Administration. There are 8 regional AETCs, and then there is a national clinical consultation center based at UCSF. They have a number of different warm lines people can call for clinical consultation around HIV, around PrEP, which is pre-exposure prophylaxis, and PEP, which is post-exposure prophylaxis, as well as pregnancy and other issues related to HIV. And there is a National Coordinating Resource Center that is based in New Jersey. And then there are a number of national HIV curricula, which are actually developed by the University of Washington. We are with the Mountain West AETC, and we serve what is essentially federal regions 8 and 10. So we serve Alaska, Colorado, North and South Dakota, Idaho, Montana, Oregon, Utah, Washington, and Wyoming. Our mission is to deliver innovative education and training to improve access to care and quality of life for people who are living with or at increased risk for acquiring HIV. We offer a number of different kinds of trainings. We do online webinars such as this. We can come to you in your organization if you are within our region. We focus on clinical issues, comorbidities such as STIs, hepatitis, substance use, and mental health disorders, as well as contextual issues such as structural and social determinants of health, stigma, trauma, carceral involvement, bias. We provide clinical consultation. We offer preceptorships. We hold conferences. We have a nursing conference coming up in Washington in June. And we have a syndemic conference happening in Montana in May, as well as a rural case management conference happening in Wyoming next week. We have a website, mwaetc.org. I encourage folks to visit our website. There you can find links to many useful resources, including the National HIV Curriculum and the brand new National HIV PrEP curriculum, which is a great resource if you want to talk to your clients about preventing HIV. We have program information there. We have a number of on-demand presentations where we have recordings of programs such as this that you can access at your convenience. And you can also sign up for our newsletter on that site. Next slide. And this is our funding acknowledgement to HRSA. Thank you.
Thank you, Lori. Just have a couple more slides with housekeeping tips to go through before we get started. Just to let everybody know, we will be sending a link to this webinar recording, the slides, as well as your certificate of attendance within a couple weeks after the webinar. You'll notice on your screen, you'll have 2 boxes. You have a chat box and a Q&A box. We do ask that you please use the chat box if you need assistance from our staff at any time throughout the presentation, or if you'd like to share respectful comments, greetings, and observations with everyone in attendance. The Q&A box, we ask that you put in direct questions to our presenter. You can do that at any time throughout the presentation. And we will be monitoring that Q&A box to answer as many questions as possible live at the end of, or towards the end of the presentation. Again, this is our QR code and a way to connect with the Northwest MHTTC and sign up for our newsletter, or if you ever need or want to email us, that is our email address at the bottom left of the screen. And as we mentioned before at the very beginning, this is our introductory session to a series that we're going to have on sexual health. So please check out our website, and here's a list of the other webinars that are coming up. Again, at the end of May, we'll have discussing and documenting sexual orientation and gender identity. In June, we're having PrEP Talk, enabling mental health professionals to lead in HIV prevention. And then in July, we're going to have the syndemic of HIV, sexually transmitted infections, and behavioral health disorders. So please do check those out on our website and get registered. With that, I will hand it over to our presenters.
Great. Thank you so much, Amy. It's really wonderful to be here today. As Amy mentioned, I'm Lydia Chwasiak. I'm the co-director of the MHTTC, and we're really delighted to be here to launch this series. This is the first of a four-part series, and particularly excited to partner with our colleagues from the AETC on this topic. This is kind of new territory for our MHTTC. We do a lot of work around integrated care, but talking specifically about sexual health and syndemic conditions is a new area, and I think it's great to have such wonderful colleagues, and I think they're excited to connect with our behavioral health workforce. So as an overview of what we're going to be talking about, we have about 45 minutes or so of a presentation that Lori and I will kind of tag team about. It's the next slide, Amy. As I said, this is a collaboration between our MHTTC and the Mountain West AETC, and we're trying to lay the foundation for the series. The topics that are upcoming over the next couple of months are really very focused on specific topics, and we're really trying to provide you all with kind of a bigger picture of the role of behavioral health providers in sexual health, identifying and addressing sexual health needs of clients, and how that can connect to well-being, social functioning, and their medical care. And so we have a very recovery-focused approach to this, and really want to highlight what we want you all to come away from this introductory session with is just a sense of how integrating sexual health into your behavioral health practice can improve the quality of the mental health care that you're providing, can help you and the people you're serving identify and address disparities, both in access to care and quality of care, excuse me, and then also help us provide holistic care and promote the health of the clients we're serving. So we wanted, before we kind of launch into the content, we wanted to get a sense of kind of who's with us today. So we have a couple of poll questions, and I'll just ask Peyton to launch those. Really trying to understand in your current work, what's your primary role? Wanting to get a sense of, are people working in what kind of the nature of your training and your background, what kind of work you're currently doing. So we'll give people a couple of minutes to chime in about their role, and if you don't see your role listed, it's kind of a short list, just chat in what the other role is, and maybe even chat in kind of the location that you're working, the kind of location that you're working in. Are you in a behavioral health center, substance use treatment center, primary care, sexual health clinic? So we'll give people a couple minutes to answer. It's like we got a lot of behavioral health providers. So nice to see. Nice to see a mix of folks, though. Great. And we also wanted to get a sense, in addition to the nature of your work, we also wanted to ask, get a sense of whether you're actually spending time in direct interactions with clients, directly providing care of clients. It helps us get a sense of, kind of thinking about future trainings, really wanting to be a little more skills-based. So helpful for us to also know how much time you're spending with clients. So it looks like a lot of clinical providers on the call.
It looks like we also have a number of substance use treatment providers, some peer specialists, some folks who work for the state, ACT team members.
Employment specialists. Yeah, it's great. And I mean, we're hoping that this information is generally relevant to all of you. So, we'll appreciate your feedback kind of at the end of the session, and it help us tailor the subsequent sessions to kind of who's in the audience. So our final poll question, I think a lot of you have gotten to, is just we want to kind of think at the outset, what's your level of comfort with this topic? Thinking about your direct work with clients, ranging from sort of 0, I'm not at all comfortable talking about this, to, kind of being extremely comfortable talking about this. It's just helpful for us to know more about kind of level of comfort. It's a big group, so it may be hard to have a lot of interactive discussion at the end, but we're hoping to learn a little bit more about some of your current practices and how things are going in your current work. So we'll talk about that at the end. So I don't know, I think we can go ahead and end the poll and just kind of look over the results. So a lot of behavioral health providers, peer specialists, a lot of people doing direct client care, and feeling a lot of comfort in the group. So that's good. Maybe that's not surprising when you're showing up today and interested in the topic. So great. Okay. So thank you for indulging us in completing those polls. So why don't we go ahead to the next slide and kind of talk about today's objectives, right? So it's really wanting, across your diverse disciplines and work settings, for you to, as a part of the behavioral health workforce, understand the importance of integrating sexual health into behavioral health care. We'd like you to also, though, consider opportunities as you're listening to information, and we're sort of sharing ideas. I want you to consider opportunities in your own setting for identifying and addressing the sexual health needs of your clients. And then at the end, we're hoping to get some input on the development of a sexual health training curriculum for behavioral health providers that our AETC colleagues would be leading the development of. So as we think about background, just kind of thinking about the current state of things, right? We're in behavioral health care, or even if it is a diverse range of settings and roles, kind of thinking about how do behavioral health providers as a group think about talking about sex. And this really interesting results. There's been a number of surveys about this, number of studies, but I thought this recent one from 2022 was particularly interesting because it was a large large cohort of about 800 mental health providers across a range of physicians, psychiatrists, psychologists, counselors, case managers, peers from 7 institutions that completed a survey of sort of how they valued behavioral health, how important they thought talking about sex was in their behavioral health work, and then what they're actually doing. And so, almost everyone endorsed that this was an important topic to discuss with clients. But interestingly, when asked, do you discuss this with more than 75% of your clients, fewer than 20% were actually doing this. And so I think that's what kind of motivated us to launch this series and to think about that gap, right? I think we all, kind of in our work in behavioral health, recognize the importance of this topic and really trying to understand, first, what gets in the way of doing this, and then second, what kind of training and support, how can we make this kind of a more seamless integration of addressing this as part of health, as part of recovery. And in this survey, when asked about, why don't more of you do this with more of your clients, the reasons were not surprising. A sense of a lack of awareness of what, kind of in the individual situation, a lack of knowledge and information about what exactly to ask, what exactly to provide resources about how to ask. And then, frankly, discomfort, provider discomfort, and also the perception of that the client would resist this. The client wouldn't want to talk to me as their behavioral health provider about this. They'd be ashamed about talking about sex. So, as we go through, you sort of think about your own situation, and but this sort of kind of sets the stage for that gap between we think it's important, we want to be doing it, but we're not doing it consistently. So in thinking about why should we ask, why should we as behavioral health providers ask our clients about sex? We want to highlight three really kind of core themes about that we'll keep coming back to in the discussion. And the first is that a sense of positive sexual health really is a central component of overall well-being and a key component of a healthy lifestyle. So really thinking about that piece of our work that is, connected to well-being, promoting health, kind of a more holistic approach. The second is really critically important, and I think about this in my own clinical work, that when we have meaningful dialogue during clinical encounters about things that are important to people, their sexual orientation, gender identity, and their sexual health, it really can promote high quality mental health care. It really can impact the quality of our rapport, the sense of trust, the sense of alliance. So really thinking about this as part of enhancing the work that we're already doing. And then finally, sexual health is a part of health. And we'll spend some time talking specifically about health risks, what I refer to as syndemic conditions of HIV, sexually transmitted infections. Talk a little bit about the alarming rates of these infections among our behavioral health clients, the very elevated risk, and really seeing our work as behavioral health providers. We're part of the healthcare system. We may be the only part of the healthcare system, or the part of the healthcare system that our clients most frequently connect with. So we are an opportunity to help them reduce risk and maintain their physical health. So what do we mean by sexual health? I think we should start by actually defining what we're talking about when we're saying sexual health. And this includes broadly sexual orientation, sexual identity, but also attitudes and values related to sex. And I think it's important, sometimes we can have a narrow, sort of a narrow scope, really think, what are we actually talking about? We're just talking about, are you having side effects from medication? Is there dysfunction? Are there issues around, someone being pregnant or wanting to be pregnant, and impact around treatment? But it's really kind of beyond just the absence of disease or dysfunction during reproductive years. And there's a definition from the World Health Organization from 2006 that I think is a really helpful kind of starting point for us. Defining sexual health as the integration of the somatic, emotional, intellectual, and social aspects of sexual being in ways that are positively enriching and that enhance personality, communication, and love. So really, very broad. And as you think about your unique relationship, right, as a behavioral health provider with clients, in your role working with clients, how can information about all of these aspects of sexual health really help improve your understanding of their situation, help you support them in understanding that, in their understanding of some challenges they're facing or things that they can do to be healthier. So the figure on the slide really talks about ways in which kind of your increased awareness of your client's sexual health can actually improve kind of their care and their well-being, improving their relationships, deciding boundaries, and just keeping up with contraception, preventive services, kind of healthcare needs. So encouraging you to think about sexual health broadly. So when we think about kind of the characteristics of a sexually healthy person, just really wanting to, the next slide, Amy, kind of talks about what we mean by someone being sexually healthy. And it really is being knowledgeable about sexuality and sexual behavior, and specifically having good sources of information, right? There's a lot of information available, a lot of misinformation available. So really, being able to point clients towards helpful resources. But it's sort of, we kind of think about someone being able to express themselves sexually, to be able to make autonomous decisions about their sexual life, but it sort of expands beyond that. And I think this is where the idea of sexual health can come up in a lot of ways during behavioral health treatment, including things like positive attitudes about body image. So essentially, we want to acknowledge that sexuality is part of people's lives and their quality of life. And one of the things we've observed, we've actually been kind of working within King County on a research pilot around building capacity for HIV prevention services. So we've been talking to a number of behavioral health providers about how they approach sexual health in with their clients. And what we're hearing a lot is that behavioral health providers can often wait for clients to raise issues related to sexuality. They might talk about that they are actually having sexual side effects from medication, or it comes up in the context of past sexual trauma or recent trauma. And so I think what we want to encourage is for behavioral health providers to be a little more proactive about this, and to be thinking about doing this more systematically, and not kind of reactively waiting for this to come up, because it, frankly, may never come up, particularly if clients don't feel like it's a safe place or you're a safe person to talk with about this. So I'm going to shift now and talk a little bit about the impact on behavioral health care, right? That was sort of a high-level overview of why it's important, how it's part of health, of well-being, of being, kind of the part of recovery, a part of a sense of well-being. But to actually kind of now spend a few minutes talking about how integrating sexual health discussions can actually impact our behavioral health care, improve our behavioral health care. So the next slide highlights a YouTube video that is a training. I don't know if Peyton told me, I think it's about a 10-minute training that was actually developed by the New York City Health and Hospitals Department. And it was a mandatory employee, it has been a mandatory employee training for more than 10 years. And it really is aimed at helping to reduce health disparities related to sexual orientation and gender identification across all of kind of New York City public health clinics and hospitals. And I think that the title of this, really resonated with me. To treat me, you have to know who I am. And I think that is really helpful as we think about our own work and how we're, working with these intimate details of people's lives, if we're providing therapy or even supporting them through case management challenges, working with them in whatever capacity we're working with them, that really, do we know who they are? Do we know what's important to them about their own identity? And so I raise this as, to kind of set the tone for why it's important to collect this information as a behavioral health provider, but then also to point out this is a really interesting training. It's a brief training. It's been a mandatory training. People have found it enormously helpful in New York City. And just thinking about this is the kind of resource that we could develop in kind of thinking about training and support for behavioral health workforce on this topic. So as we sort of ask about what kind of training would be helpful, thinking about something like this kind of training. So thinking about you have to know who I am. understanding someone's sexual identity really it can be very important for a number of reasons that I'll talk about in a minute. But to just highlight that there are, more than 9 million LGBTQ people in the US. And so I think it can be easy for providers working in very narrowly focused specialty settings to think, oh, this isn't, this isn't so important for me. This is not, it's not a topic that I'm going to encounter, and to just really highlight that it's fair to assume that this issue is that you're seeing folks on a regular basis, and it's important to kind of understand people's identity and orientation to identify and address disparities. So on the next slide kind of shares some statistics, particularly about LGBTQ youth and elevated rates of mental health issues. And, concerning particularly around elevated rates of suicidal ideation. Nearly 3 times, the Trevor Project consistently collects data for national surveys and finding that more than a third of LGBTQ youth seriously contemplated suicide in the prior year, 3 times the rate of peers, and concerningly, almost half wanting counseling from a mental health professional but not receiving it. So this idea of elevated rates of symptoms, of suicidal ideation, unique barriers to access to mental health care, these are things that we should be thinking about in our own practice, but just largely as sort of a behavioral health provider community. The next slide shares just additional data. This is also from the Trevor Project, of just really elevated rates of generalized anxiety among transgender and non-binary youth, and symptoms of major depressive disorder in the last couple of weeks. Again, among transgender and non-binary youth. So as you think about clients, really, making sure that you're screening for these symptoms, that you're asking about suicide, that you're aware of this level of increased risk. So, and this is not only true for youth. There's also data suggesting high rates of depression, anxiety, and substance misuse among LGBTQIA plus adult individuals. Again, high rates of suicide and just kind of overall having more likely to have a mental health disorder in their lifetime. So really thinking about this as a group that is at increased risk of these disorders and facing inequities in access to any care, or to high quality care, or to care that is specifically tailored to their needs, that is useful to them and likely to be helpful to them. And, just kind of thinking about the reasons why these symptoms of depression and anxiety might be higher, stressful experiences throughout lifetime of feeling different from others, feeling pressured to deny or change their sexuality, feeling worried about coming out or being rejected or isolated, and just feeling unsupported or misunderstood. And so really wanting in our behavioral health care, in our relationships, to not reinforce feeling unsupported or misunderstood, but actually to be able to have a more genuine and authentic interaction with our clients. The next slide similarly shows, this is among adults, kind of looking at data from a US Census Bureau. It's called the Household Pulse Survey, and it basically just shows increased rates of depression and anxiety across all age groups among LGBTQ adults. It's on the next slide, Amy. So really looking at percentage of adults. On the left is symptoms of anxiety, on the right is symptoms of depression. And again, we see a lot of high rates of symptoms in youth and young adults, but really across the lifespan, this continues to be a challenge and continues to be, the risk continues to be elevated. So I'll turn over to Lori in a minute. I think I just on the next slide wanted to, kind of open this sort of next section and really thinking about sexual health as part of health and wanting to encourage behavioral health providers to think about a sexual history as part of routine healthcare, that this is something that is where we're providing healthcare within behavioral health settings. We really want to think of a sexual history. And by asking all clients, a few essential questions, we can help remove the stigma around discussing this and really normalize the conversations. And as we are discussing sexual health, it really provides us with opportunities to gain an overall picture of our clients' health, to counsel and share information about behaviors that might increase risk of STIs, HIV, hepatitis C, and to screen for and treat STIs and address other sexual health concerns that we'll talk about in a minute. But let me turn it over to Lori to present some data about HIV.
Sure. Next slide, please. So I'm going to focus a little bit more specifically on HIV. Someone recently recounted to me that she was somewhere and someone said to her, "Is HIV still a thing?" And the answer is yes. HIV is still a thing. And here in the US, there are over 1 million people living with HIV. And the reality is that we have gotten really, really, really good at treating HIV. Treatment has improved drastically. So we're going to be seeing more people living with HIV, not fewer, even as we're able to hopefully reduce HIV transmission because people are living so much longer than they used to. We could be doing a lot better at identifying HIV than we do. Although these statistics are old, they're from 2016, things haven't really changed that dramatically. About 1 in 8 folks don't know they have HIV, and a significant percent of new HIV transmission is happening among people who don't know they have HIV. And then we see that about 20% of folks already have an AIDS-defining diagnosis at the time that they're diagnosed with HIV, which means that they've had HIV for a number of years and their immune system has already deteriorated beyond a certain level. And certainly during all that time, they didn't know they had HIV. There were opportunities for transmission to occur and lost opportunity for them to get on treatment before HIV had more of an effect on their bodies. And we know that people with serious mental illness are more likely to acquire HIV than the general population, as are people who use drugs, men who have sex with men, folks who are transgender, people who are BIPOC have much higher rates of acquiring HIV than the white population has right now. And so it's important as we think about sexuality and intimacy as important parts of people's lives, as important components of recovery, to really be exploring with folks, how are they keeping themselves sexually healthy? How knowledgeable are they about their own sexual health? The importance of HIV screening. Are you asking your clients if they have been tested for HIV? The CDC recommends everybody be tested at least once in their lifetime, and that people who are at increased risk should be tested more often. Given what you know about your clients and their ongoing risk, when was the last time they were tested for HIV? Should they have another HIV test? How are they protecting themselves from disease? Not only HIV, but right now we have an exploding epidemic of STIs. Syphilis is at its highest rate since I think the 1950s, and we're seeing high rates of congenital syphilis, which we also have not seen in many, many years. And the same way you prevent HIV is also, in some instances, the same way you prevent other sexually transmitted infections, although we do have some HIV specific prevention that does not protect against other STIs, but people can be being screened more often, because once you identify somebody as having HIV, they can be linked to care. They can get immediately into treatment. The sooner somebody gets into treatment, the more effective that treatment is. The other thing that is critical about getting people into treatment is what is known as U equals U, undetectable equals untransmittable, meaning that if somebody's viral load, if someone is on effective treatment, it keeps their virus from reproducing. And if their viral load is what's called undetectable, which means it's at either 0 or very low rates, they cannot transmit HIV sexually to another partner. So having people identified as having HIV and engaged in treatment is as important for preventing new cases of HIV infection as it is for that person's own clinical outcomes. Next slide, please. So when we look at who's getting HIV, it continues to affect different groups of people disproportionately. Roughly 3/4 of folks in the US who are diagnosed with HIV are male. That statistic is different in different countries. In places like sub-Saharan Africa, it's more equally among men and women. Actually, more young women get diagnosed at higher rates. But here in the US, we still see it's very heavily male, certainly male-to-male sexual contact, people who are injecting drugs, people who are having sex with folks who inject drugs, people who engage in transactional sex, people whose partners are at increased risk for HIV. A lot of people, women in particular, acquire HIV through their primary partner. Also, we see that different racial groups are disproportionately impacted by HIV. In 2021, when we look at go back. When we look at the incidence of people who have HIV, roughly 40% are Black, even though Black people are only 12% of the US population. About 25% are white, about 29% are Hispanic. And what we find is that Indigenous people are often invisible in when we look at national data, because they are a small percent of the total US population. But when we look at rates in those populations, they're also significantly higher than they're significantly high. Next slide, please. So when we look at age, new HIV is being acquired mostly among younger folks, people who are under the age of 34. So as you're looking at your client population, it's really important to explore these risk factors as well as screening with younger folks, although HIV is actually becoming much more prevalent among older populations. It used to be that only about 10% of folks living with HIV were over the age of 50, and now more than half of people with HIV are over the age of 50, which really speaks again to the effective treatment. And we have a large body of folks who are aging with HIV, people who got infected in the 90s and in the early 2000s, and even back in the 80s, who are still living with HIV. Next slide, please. So I want to focus a little bit on individuals who are transgender, and this is because of really elevated disproportional HIV risk and under-identification in this population. There are about 1 million people in the US who identify as transgender, as non-binary, as something other than traditionally being in alignment with what is often referred to these days as sex assigned at birth. New diagnoses are going up in this population. And again, we look at what is the disproportionate rate of folks who already have AIDS at the time of HIV diagnosis. A stunning statistic, or at least I found it a stunning statistic, is that trans women are 49 times more likely than others to acquire HIV, and that more than 50% of trans women of color will acquire HIV in their lifetime. That is the group that is at the most disproportionate risk of acquiring HIV. And again, they may not be correctly classified. They're often invisible in regular statistics, and people aren't asking them what it is that they need. Next slide, please. So there was a survey done, a national survey using 7 cities: Seattle, Los Angeles, San Francisco, New Orleans, New York City, Philadelphia, and Atlanta. A behavioral health surveillance study where they did a survey of over 1,600 women who identified as transgender, and these were in cities with significant rates of HIV within those cities. And 42% of these women already had HIV. Nearly 2/3 of the Black trans women were positive for HIV. And although they're not shown in this chart, again, because of their small numbers, the rates were similar for trans women who were indigenous. Again, indigenous people are often erased in our data, and so they become invisible as we're discussing and exploring these problems. About 1/3 of trans women who identified as Hispanic or Latina had HIV, and a much smaller percent of those who were white. There are a lot of social and structural issues that contribute to the high rates of HIV in this population. Many engage in survival sex in order to support themselves economically. It's also important to focus on in this population because, again, as Lydia mentioned earlier, there are higher rates of mental health issues, depression, suicide, experience of trauma, surviving violence. And also anyone who wants gender affirming surgery needs to get a letter from a psychiatrist. So they're very likely to be engaged in the mental health system in some way. Next slide, please. So here is showing the rates of women of trans women who are HIV negative, and how much they knew about PrEP and how many of them were actually on PrEP. For anyone who's not familiar, PrEP is pre-exposure prophylaxis. You can either take daily pills or bi-monthly injections that prevent HIV transmission. They do not prevent transmission of other STIs, but they do prevent transmission of HIV. And given the rates of HIV in this population, it is really inexcusable that we are not doing a better job of getting trans women onto PrEP. So these are really essential conversations to be having with these women, to help them get onto PrEP. Alarmingly, It's a very small percent, roughly 2/3 of trans women who are on PrEP are white. And only about 13 or 4, between 13 and 14% are Black. And given what I just told you about the rates of who is acquiring HIV, there is a big disconnect between who we're offering PrEP to and who is at greatest risk of acquiring HIV. And so as you see folks in your practice, I think this is a place where you can really make a very big difference in helping to keep people from acquiring HIV and also for helping people to get into care. And I'm going to turn it back to Lydia over here.
Great, thanks, Lori. And I think that's right. That's a really that powerful kind of image of the distance between people knowing about PrEP, knowing that PrEP is 99% effective in preventing HIV transmission, but then how many are actually maintaining, how many are prescribed PrEP and maintaining PrEP. And as you said, this is our opportunity as behavioral health providers for us to be able to identify a need, troubleshoot challenges, really get people access to this critical preventive service. So, we'll talk about, we'll kind of close in talking about this endemic of mental illness, behavioral health disorders generally, and sexually transmitted infections. And Lori alluded to a number of the key pieces of this, right? So a syndemic, many of you may be familiar with this term. It's a concept that was proposed in the mid-90s that really talks about 2 or more illness states that interact negatively with each other and kind of negatively influence the trajectory of each illness. And as this thinking has evolved about syndemics over the last couple of decades, we've really recognized the importance of social factors in sort of contributing to negative interactions among disorders. So we're thinking about substance use disorders, adverse mental disorders or mental health symptoms, HIV infection, STIs, kind of in the context of violence, people experiencing homelessness, poverty generally, and just how this mutually reinforces poor outcomes and contributes to perpetuating adverse social conditions. So want to talk a little bit and kind of move beyond HIV and talk about STIs generally, that the US has the highest rate of STIs in the industrialized world. In 2022, are the numbers from the CDC, 2.5 million cases of chlamydia, gonorrhea, or syphilis, and half of those in young people, 15 to 24 years old. So, kind of thinking about just who's at great risk and particularly vulnerable. Of great concern, I'll show you some slides with trajectories in a minute, but that the rate of chlamydia has increased by 21% over the last 4 or 5 years. But gonorrhea and syphilis in particular has just kind of exploded nationally. And it's among people with serious mental illness, and particularly among people who use methamphetamines. And as Lori alluded to, this is people presenting kind of with late-stage syphilis, pregnant people being infected and leading to congenital syphilis. And this is, sort of disease states that we haven't seen in the US for many decades. And, the statistics are so alarming, and our behavioral health clients are at such a high risk that the director of SAMHSA actually released a letter in January. It was kind of a general letter to behavioral health. It was to SAMHSA grantees, but to behavioral health providers, where she specifically said, I think the quote is on the next slide, Amy, specifically said that screening, testing, and treating sexually transmitted infections is part of SAMHSA's whole person approach to behavioral health treatment and substance use prevention. So really, kind of a call to action for all of us that we have got to be thinking about this tremendous risk to our clients and their future children, and kind of thinking about what is our role, how do we position ourselves to either to help identify and even potentially provide some of the screening, testing, and in some settings, even treatment. So kind of thinking about where you're working, what resources are available. Do you know the resources in your area that you can connect people to? So just to show some of these statistics, particularly about syphilis, this is some CDC data that really looks, again, charting kind of what's the rates of reported cases by stage of infection. So the top, you're kind of looking between 2013 and 2022, you see this sort of steady climb of total syphilis cases till about 2020. It's interesting how this sort of intersects with the COVID pandemic, but kind of a steady rise, and then just this tremendous uptick of total syphilis cases over the last couple of years. And it's continuing to rise, right? Just the data that's not in the that CDC is continuing to report over the last 2 years, it's continuing to rise. But of particular concern is we see this either unknown duration or late syphilis. So these are people who can have much more serious medical consequences from their syphilis infection, including neurosyphilis. So, very concerning that people are presenting late. And as I mentioned, so this is in 2022, for example, there were 207,200 and some total cases of syphilis, and about 87,000 of them, so almost half of them, were late stage syphilis on presentation. And as we think about sort of between 2021 to 2022, the total rate of syphilis increased by about 17%. But when we look at the difference between the increase between 2018 and 2022, it's that 76%. So really seeing a tremendous rate in the increase of new infections of syphilis. And again, sort of echoing the theme that Lori presented with HIV infection, the next slide just shows kind of the disproportionate impact on people of color. So when we look at new syphilis cases, CDC data reports them by race and ethnicity, seeing very, very high rates among indigenous populations and people of color, in particular, people who are Black. So really thinking about, who's at risk, who's at particular risk, how do we communicate most effectively about risk, about preventive services, about accessing screening and testing, kind of thinking about your own particular population. So we'll end with just a couple of comments. It seems like just from the chat, it seems like it's a fairly sophisticated audience. So, but for general information, just highlighting the importance of taking a sexual history. I think our recommendation is that this really should be part of care for all adolescent and adult clients. It really helps identify their needs, their sexual health needs, including need for PrEP or for syphilis screening, but kind of thinking about their health needs, and just encouraging providers to make this a routine and to reassure clients that it's routine and confidential. And there are a couple of resources that we wanted to share, a couple of handbooks. CDC has one that really help kind of provide sort of job aids and kind of coaching around how to take a sexual history, and really just being able to to be able to communicate that this is a brief sexual history is a routine part of our intake, that everything you say is confidential, reassuring clients about that. The CDC resource that I was referring to highlights kind of starting the conversation and continuing the conversation about sexual health. So the next slide just has a couple of bullet points around starting a conversation about sexual health. And I think just the things that are kind of intuitive and are probably you're all very familiar with, but just thinking about assessing your own comfort. I'm trying to identify any biases that you might have that might make your client uncomfortable in talking about their own their own lives, their own sexual health. Important to avoid making assumptions based on just generalities, someone's age, someone's life situation, their marital status. To really just ask everybody the same questions. being able to gather basic information during an initial assessment. And I think, this is something I hope we're all practicing, kind of asking people what name they'd like to be called, what pronouns they use, their sexual orientation and gender identity, to really just a part of rapport building and establishing that therapeutic alliance. And then, for gender identity, this kind of two-step method of asking about sex assigned at birth, just for, thinking about medical issues or general health care, but then also asking about current gender identity. Again, asking about pronouns and terminology, but we'll have a whole session. Our next webinar is about collecting and documenting SOGI information, and using neutral and inclusive terms, making clients feel comfortable. I mean, these are things you're doing anyway, but I think it's helpful the way the handbook kind of puts these all in the same kind of in one place, and it's helpful for training new clinicians and just really thinking about standardizing an approach across an organization. The next slide actually shows the CDC handbook on taking a sexual history, and provides, in addition to this, starting the conversation, kind of how to keep the conversation going. And I think part of it is like, what do you ask and how do you ask? But it's also just kind of checking in about yourself, right? Like, it's almost like sort of, kind of transference checking. Like, are you, how are you reacting? Are you communicating clearly? Are you checking that your client understands, the information you're providing, thinking about your body language? Are you feeling uncomfortable? I mean, really just being very aware and very present during these conversations, being self-aware. This guide and others kind of have a general approach to sexual health, sexual history data collection. It's called the 5 Ps of sexual health. They're illustrated on the next slide. And, just really thinking about the kinds of questions the topics that you want to explore with people. So talking about partners, talking about practices, pregnancy, history and plans, and then protection from STIs and past STIs. And I think as the thinking has evolved, I mean, this is kind of the CDC guide, and Lori can speak a little bit more to this. As the experience and thinking about this has evolved, the 5 Ps have expanded to include additional topic areas about preferences and problems, and really specifically asking about violence or abuse within relationships. So I'm going to end with just reminding, Amy had shared this at the outset, this is the series. I should acknowledge that this, the idea for the series, or the content of the series, came from a really wonderful, longer and more comprehensive series that the AETC has been offering for several years essentially for primary care providers, sexual health providers. And we pulled out topics we thought might be of particular interest to our behavioral health audience. So this is on our website, it's on the AETC website, so you can see sort of the dates and the topics and the presenters. But what we'd like to do, I think we have about a half an hour left to kind of open it up a little bit for Q&A. Then before we start taking questions from folks, we wanted to just ask a couple of more questions just from you, so we can be thinking about our future offerings. So I don't know, Peyton, kind of launching the Mentimeter around what are the main challenges to discussing sexual health with your clients? And I don't know if Peyton, if you want to chime in, or Amy. I think it's pretty straightforward to just click on the QR code and it should come up, and you should be able to type in some brief answers. But really just curious, kind of in your experience, what are the barriers you're facing? So we'll give people a couple of minutes to respond. And then we'll have another brief question, and then we'll kind of open it up to Q&A. People accessing the QR code. I know, Peyton, you want to chime in with any?
There we go. Excellent.
Excellent. So lack of knowledge, stigma, religious practice, short-term care. I think that's a really interesting, kind of the nature of the relationship. It's something, as we think about opportunities, emergency rooms, crisis clinics are opportunities to kind of screen and test, but really establishing, taking detailed history information, working with people, counseling people, really, it is better within the context of a relationship, a therapeutic alliance. So how do we create that in shorter contents, context of shorter treatment?
I also think, some of the things people are writing about 15-minute visits and lack of time, right? So how much can you cover when you're really being pressured to get people in and out? Yeah, I noticed, people wrote about client discomfort, and it's interesting the number of surveys that have shown that clients really want to be asked by providers about their sexual health. They want their providers to start the conversation. I think they're uncomfortable starting the conversation, but they're not necessarily uncomfortable sharing the information if they're asked in a non-judgmental, kind of normalized way, and they can often feel relieved at having the opportunity to talk about things that may be concerning to them, but that, they may have some shame around, or, discomfort about feeling or not knowing how to bring up.
Yeah, I really appreciate people typing in these responses, because, just kind of pulling out sort of themes or sort of challenges at multiple levels, right? There's no community awareness. There's sort of a lot of individual client level issues, including parent involvement for young clients. There's provider level challenges, the nature of the care, length of visit, length of treatment, and then kind of organizational level one. So really, as we think about how to more systematically approach integrating this, where do we want to intervene? How can we think about strategies that can address some of these barriers at these very different levels? So so appreciate. And then, of course, stigma, biases, transphobia. I mean, all of these things are just coming up in the context of our work.
And I think the triggering piece is really important to be sensitive to, especially I'm sure many of your clients have, histories of sexual abuse and, some of those kinds of concerns. Another thing I noticed somebody had indicated was age gap. And I think thinking about how well you are or aren't matched with your clients, right? Like an older person might be less comfortable disclosing some things to a younger person, or in certain cultures, men and women don't talk about certain things together. Are you the same gender as the person in front of you? And is that going to be an issue for them? So sometimes those things can be barriers as well, certainly.
So thinking not only about your practice, but, again, the individual in front of you, what unique factors might be contributing in their case, whether it's cultural factors or past history of trauma. Great. Well, I appreciate this input. We have another question that really is more specifically focused on, right? We kind of did our best in putting our heads together around 4 topics, but really want to think about, are there other topics related to sexual health that, you'd like more information or training on? How might we think about this? How might the AETC think about providing something that's a little more tailored to behavioral health audiences? So just really curious, it's kind of for our own benefit about future offerings. What would you like to, I think some people had chatted in a couple of topics, but, kind of.
Yeah, and while folks are answering that, I do want to remind people that anybody would be welcome to attend our monthly sexual health series, or any of our other programs. And if you go to the website, you can easily sign up for those.
Mm-hmm. Great, so we'll give you a couple minutes but we're saving these and keeping track of them and thinking about future sessions and future ideas. So keep those coming, and then I don't know, Amy, maybe we can move to taking some. Lori and I can take some questions from the Q&A.
Yeah, absolutely. I can share those. Did have a question regarding, well, I'll just read it. Do you have any recommended or standardized scales or instruments to establish initial interviews, rapport, data collection, etc.?
Yeah, that's a great, I mean, we can start with kind of the data collection. That is the topic of the next webinar series, kind of best practices around SOGI data collection. So I don't know if you want to respond briefly to that, Lori, but we're recognizing how important that is and how important it is to kind of standardize that. We're dedicating a session to that.
Yeah. The woman who is presenting on that next month, she runs our Oregon site, and the state of Oregon has actually mandated what data needs to be collected around this for their state. There is not a national consensus on this, and I haven't, beyond what I know they're doing in Oregon. I don't know that I've seen, like, oh, well, here's the best practice, scale for what you should use for collecting this information. Although I do think what they're doing is quite good, and we've adapted some of our demographic collection to try to mirror some of what they're doing.
And I'll add, it's not actually answering the exact question, but as we think about just trying to standardize, it's data collection instruments, but it's also kind of the workflow, like if we're collecting information or we're integrating this into our work, which staff members are doing it, in what context, really kind of from a clinic or a team or a clinic or an organizational level, how will this be integrated and supported? How can it be made easy for data entry? So it's sort of thinking beyond the data collection instruments, but also how to support integrating this into the existing workflow.
Thank you both. Our next question is regarding PrEP. And the statement is, as someone who has been on PrEP, I'm required to meet with my healthcare provider every 3 months in order to refill my prescription. It's extremely easy to lapse in care if I miss my appointment. Are you able to speak on ways to keep people coming to clinics with these current regulations?
Yeah, so I think one of the regulations that I think has been the biggest hurdle for folks is the need for for lab testing and HIV screening every 3 months. But you don't necessarily have to go to the clinic to get that. There are a number of pharmacies that are now offering pharmacy-led PrEP, and it may be possible to find, I don't know where you live, it may be possible to find out if there's a pharmacy in your area that's offering PrEP, or if your provider knows of a pharmacy in the area, because you may just be able to go to your local pharmacy and have that done rather than have to go to the clinic to get these things done.
And I think hearing from our behavioral health providers that is the main barrier to providing PrEP, right? It's not that challenging for psychiatrists or psychiatric prescribers to prescribe it. It's having the capacity, the infrastructure to do that monitoring. So could we make it available in behavioral health organizations, and would that make it more accessible to our clients? Something we're thinking about. Long-acting PrEP is another option, but it doesn't address the need for ongoing monitoring.
Yeah. There was a question that I saw in the chat, and I know it's also in the Q&A. I wanted to make sure that I'm able to speak to, which was the slide from CDC talked about male-to-male sex, and the concern was that's not a particularly trans-inclusive way of referring to risk, and I think increasingly we're learning to talk about body parts rather than gender. I mean, we even talk about pregnant people now. And I originally, when CDC created these categories, a lot of men who were engaging in risky sex with other males did not identify as gay. They did not identify as bisexual. And so the idea was, well, if we're saying it's male to male sex, that would be inclusive of all these folks with penises who were engaging in sexual activities through which they were acquiring HIV. For women, they were calling it heterosexual contact, and they were not, there's no distinguishing of whether they're getting HIV through vaginal sex or through rectal sex. But we just know that they're getting HIV through some type of receptive sex. So it would be very interesting to see if CDC would be willing to switch over to language that talks about, penis to rectal, but then I don't know that they're going to be willing to walk away from male and female gender and then have some other kind of gender. As we've seen, the smaller numbers of folks tend to be made invisible in the data. So I'm not sure what the best way is to have CDC address that, but it's certainly an issue worth raising within the HIV unit within CDC, because they're the ones who determine, all the language and how things are shown on their websites. We've tried to talk to them about things like their general racial disparity data really centers whiteness, and that there are other ways of presenting data that might do that less. But getting CDC to shift how they do things, that doesn't always turn on a dime. And if anyone has suggestions around it, because I do think talking about, yes, it's receptive anal sex that carries by far the greatest risk, although clearly insertive partners also acquire HIV, or there wouldn't be a chain of transmission, right? So I do think it's time to examine how that is presented. But I'm not sure what the best ways are for them to really parse that out. But I think it could be done better than it's being done now.
Thanks, Lori.
Yeah,
I think we
thank
have
you,
time
Lori.
for one more question. I see that Peyton has put the link in for the evaluation. So, please feel free to continue to type in topics that you'd like us to think about addressing, or provide resources related to complete the evaluation if you need to leave early, but we're happy to take additional questions.
We do have one more question. It is in regards to data. This person is curious why it seems presumed that partner or married people are at lower risk given relatively high incidences of unconsensual non-monogamy, which includes sexual abuse and cheating. So are there any rates or data rates that you both know of regarding this?
This should not be a presumption. That's, the recommendation is to talk to all patients, regardless of marital status, to screen all patients, regardless of marital or partner status. I think I mentioned earlier, in particular for women, often their greatest risk is being in a primary relationship. Being married can be your biggest risk because you don't control your partner's behavior. So yeah, so it's important for that to not be the presumption.
Great.
Thank you. We don't have any more questions in the Q&A.
Great. So, well, we just want to thank everyone for attending. You've had some great feedback, and that's been really helpful for us to hear kind of your perspectives. We'll take a look at the topics that you're interested in. I want to thank our AETC partners for their collaboration on this. We're looking forward to the rest of the series. And Amy, you want to just remind us the date and time of the next session? Yeah, so it'll be the discussing and documenting SOGI with Dana Morrison from the AETC on Wednesday, May 29th at 12:30. So we'll look forward to seeing many of you there, and I appreciate you joining us today.
Thank you both so much for presenting. Really appreciate it. Let's go ahead and put up our QR code just in case. I know the link is also in the chat regarding our evaluation, and just knowing that your feedback is so important to us. I want to thank everybody for being here, taking the time to be here out of your busy days. And thank you both, Lydia and Lori, for being here as well. I know you both are very busy too. So thank you everybody for being here, and check out our website and the AETC for upcoming events.